Hello everybody, today we have an interview with one of the famousest surgeon. Every time we will discuss one of the common surgical problems. Today we will discuss management of splenic injury. Hello doctor and welcome to our studio and our YouTube channel no1doctor.
Hello. Thanks for you and all your channel subscribers.
Doctor. A man has sustained blunt abdominal trauma and has the suspicion of splenic injury. How will you manage?
The initial management consists of primary survey and resuscitation, secondary survey, details history, examination and relevant investigations, definitive management.
Doctor. What are the types of splenic injury?
Types of splenic injury: subcapsular hematoma, laceration of spleen, polar tear, avulsion of splenic pedicle.
Doctor. What are the different clinical presentations of splenic injury?
Patient may present with classical features of splenic injuries, seen in case with severe injuries in polar tear. Silent history of abdominal trauma with impact on left upper quadrant. There may be slight abdominal pain with no other symptoms and signs. The splenic injury is diagnosed by ultrasonography. Delayed rupture of spleen, seen in subcapsular hematoma when there is mild left hypochondriac pain with no symptoms or signs at initial presentation and the injury is often missed. After 7 to 14 days, the hematoma grows and ruptures. Patient presents with symptoms and signs of intraperitoneal hemorrhage.
Doctor. What are the classical features of major splenic trauma?
The manifestations of splenic trauma may be general symptoms and signs of internal hemorrhage, pallor, tachycardia, hypertension, restlessness, sweating, deep, sighing respiration, cold, clammy extremities, collapsed veins. Abdominal symptoms and signs of splenic rupture. There may be cutaneous bruising in the left upper quadrant of abdomen. Increasing left upper abdominal pain and tenderness. Increasing left upper abdominal rigidity. Increasing abdominal distension. Diminished or absent bowel sounds. Kes sign may be present. Elevation of the foot end of the bed causes pain in the left shoulder. Balances sign. Fixed dullness in the left flank due to clotted blood around the spleen and shifting dullness in the right flank due to unclotted blood in the peritoneal cavity.
Doctor. Which investigations may help in diagnosis of splenic trauma?
Complete hemogram. Initially hemoglobin percentage may be normal for 6 hours as hemodilution does not occur. Leukocytosis may be present. Straight X-ray of abdomen with both lomes of diaphragm. Findings may be increase in splenic shadow with haziness. Obliteration of left psoas shadow. There may be indentation of fundic gas shadow. Left colonic gas shadow displaced downwards. Free fluid between gas-filled intestinal coils. Associated rib fractures on left side. Elevation of left lobe of diaphragm. Basal pleural effusion on left side. Ultrasonography of abdomen is investigation of choice. It can diagnose small tear, subcapsular hematoma, free blood in peritoneal cavity, CT scan of abdomen, if ultrasound is inconclusive and there is strong suspicion of injury. CT scan of abdomen is done for diagnosis of small tear. Diagnostic peritoneal lavage. Positive in splenic trauma with intraperitoneal hemorrhage.
Doctor. How will you treat subcapsular hematoma of spleen?
If there is no other injuries requiring laparotomy, the subcapsular hematoma of spleen may be managed successfully with conservative treatment. Patients should be treated in an intensive therapy unit. Adequate fluid replacement intravenous or orally if no vomiting. Parenteral antibiotics. Blood requisitioned and reserved. Intensive monitoring is the most important part of conservative management. Clinically, pulse, BP, respiration are to be checked every hourly. Laboratory, serial hematocrit. Radiological, Serial ultrasound every 24 hours. If the patient is stable, hematoma is not increasing and shows signs of regression conservative, treatment may be continued. If the hematoma is expanding and there is evidence of free intraperitoneal rupture, immediate laparotomy is to be done.
Doctor, what are the indications of laparotomy in splenic trauma?
Severe degree of splenic injury with symptoms and signs of intraperitoneal hemorrhage. Minor splenic injury associated with other intra-abdominal injury requiring laparotomy. Failure of conservative treatment of splenic injury.
Doctor, how will you manage splenic injury on exploratory laparotomy?
Earlier the dictum for treatment of splenic injury was splenectomy. In view of serious post-splenectomy complications, the recent trend is to conserve spleen unless the organ is extensively shattered and bleeding is uncontrollable. Small capsular tear. Control bleeding with local hemostatic agent like oxidized regenerated cellulose, Surgicel, or fibrin glue. If it fails splenography, the bleeding from the splenic tear may be controlled with a serous Mrcs suture. Polar tear may be managed with partial splenectomy. Extensive laceration or avulsion of splenic pedicles. Splenectomy is to be done. If splenectomy is done, a portion of the spleen, 6 pieces of 40 by 40 by 3 mm, may be implanted within the leaf of greater omentum, splenic slice graft.
Doctor, what are the complications of splenectomy?
Bleeding. Left basal atelectasis. Pleural effusion. Gastric fistula due to greater curvature injury while ligating short gastric vessels. Pancreatic fistula due to damage to tail of pancreas. Thrombocytosis is the rule following splenectomy. Patients need prophylaxis against thrombosis with unfractionated heparin or low molecular weight heparin. Overwhelming post-splenectomy infection, OPSI. Spleen is the crucial site for production of opsonin and propagin that helps in phagocytosis of encapsulated bacteria. Following splenectomy, the commonest form of OPSI is pneumococcal or meningococcal septicemia. In addition, infection with Haemophilus influenzae is also common. Diagnosis of OPSI. Infection starts insidiously but rapidly develops into a fulminant infection. Fever, vomiting, dehydration and circulatory collapse may occur. Hemogram. Show leukocytosis. Blood culture may show the organisms. Treatment of OPSI. Intravenous fluid. Broad-spectrum parenteral antibiotics. Prophylaxis against OPSI. Antibiotic prophylaxis using penicillin, retrimycin or amoxicillin and coamoxiclave combination. Vaccination against pneumococcus and H. influenza. 1 dose in the immediate preoperative period and needs to be repeated every 10 years.
Thanks, Doctor.
Thanks for you and for your subscribers.
Thanks for watching. Hope to see you again in next videos. Do not forget to like and share our videos and subscribe to our YouTube channel no1doctor and share our videos with your friends on social media. With my best wishes. Dr. 8 Famid.